Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Graduation at the Johns Hopkins Bloomberg School of Public Health is just a few days away, and today, in our annual tradition, Dr. Josh Sharfstein interviews a new graduate. Jeff Marr, soon to be Dr. Jeff Marr, is a doctoral candidate in health policy and management. He speaks with Dr. Sharfstein about his path to public health, his research on the use of algorithms and artificial intelligence by insurance companies, and what's next in his career. Let's listen.
Jeff Marr, thank you so much for joining me today on Public Health on Call. Congratulations on your upcoming graduation.
Thank you.
So I'd like to talk to you about first your road to public health. Tell me a little bit about yourself.
Yeah. So I guess I'll start with my first job in healthcare was when I was in college, and I worked for a safety net healthcare system in upstate New York. This was when I was in college, a pretty young person, and really got to see what it was like for a healthcare organization to think about how do we improve quality, how do we expand access, and how do we innovate within the constraints that's set out for us by our payers, whether that's Medicare, whether that's Medicaid, whether that's commercial insurance. And so really got to see this early glimpse into what is the healthcare system doing and what are the questions that matter to people who are making decisions within healthcare organizations.
What was your major in college?
Yes. So this is sort of I would say the two things that pushed me to study health policy, right, was this on the ground, okay, this is how healthcare organizations make decisions. And at the same time, I was an economics major. And I really have appreciated the tools of economics, right, both in theory and the empirical tools of economics. And I think that gives us a lot of ability to try to ask the type of questions that matter for understanding healthcare markets and public policy. And so I think I study health policy as a combination of those two early experiences in college of seeing how healthcare organizations were making decisions, and then having the academic framework of economics to, okay, this is how we study healthcare organizations, this is how we study healthcare markets.
And how does that set of interests, that combined set of interests, take you to Johns Hopkins?
Yeah, so I got very interested in what Medicare was doing. At the time, there was a lot of interest in payment reform and various sorts of alternative payment models that I think really lent themselves to empirical study. And there's been a lot of great empirical work on those types of programs.
And you're talking about different ways of paying doctors and hospitals so that they actually deliver better care and that patients are healthier. And you wanted to study whether that actually worked.
Exactly. And so after I finished college, I worked on studying these types of payment policies in Medicare and Medicaid for 3 years, and then came to Hopkins, where I have spent the last 4 years and have just finished my PhD in health economics and policy from the Health Policy and Management Department here at Hopkins.
And was it everything that you thought it would be?
Yeah, it was a fantastic experience here at Hopkins, and I think really allowed me to combine developing institutional knowledge about how healthcare works on the one hand, and then getting the tools from economics that I wanted to be able to study these sorts of questions.
So, if I'm not mistaken, as part of a PhD, you have to write a dissertation. Tell me a little bit about what you decided to pour your energy into while you were here studying health policy at Johns Hopkins.
Yeah, so I've really focused on the behavior of health insurers and how that impacts how patients get care, the quality of care that they get, right? And so in my dissertation, I look at what happens when health insurers begin using predictive algorithms to make decisions on a personalized basis about what healthcare to cover and what healthcare to deny, right? So going in and for a specific patient saying, you get this amount of care and we will deny any care beyond that, right?
Let's back up for a second. Predictive algorithm. What exactly is a predictive algorithm?
So it's a little bit black boxy. And
Mm.
actually, it's been very interesting to study algorithms because they tend to be proprietary, like these health insurers and the companies that use these algorithms are not necessarily super transparent about what's going on. But basically, this is in the context of people staying at skilled nursing facility after a hospitalization, right? So getting rehab, getting skilled nursing services, right? After, say, you're in a hospital for a couple of days and then you spend a couple of weeks in a skilled nursing facility getting this type of care. And so what this algorithm does is it predicts based on how, some things we know about the patient, their functional status, their clinical status, and how long the algorithm makes a prediction of how long the patient should stay in a skilled nursing facility to meet some sorts of objectives, which are a little bit opaque.
So let me see if I get this straight. I go to
Yes.
the hospital. I need some rehab. They send me to a skilled nursing facility, and my insurer has to decide how many days to pay for.
Exactly.
And it might say, well, based on Josh's age, the conditions he has, some other factors that are a little bit unclear to us, but certainly not totally unclear to the health insurer, they're going to say, we're going to pay for 6 days for Josh at the skilled nursing facility.
Exactly.
But for Jeff, different set of circumstances. Maybe you get 4 days, maybe you get 8 days.
Exactly.
And your question is, well, what's behind these clinical algorithms? What are you asking about the ways that health insurers make decisions on how much to cover?
So what I do is I study the causal effect of this practice, right? And so what I do is I use a natural experiment I know this one very large health insurer began doing this on a specific time. I look before and after that happened. I have a comparison group of people who are not affected by the algorithm, and I can estimate what was the causal effect of this algorithm.
In other words, what impact this algorithm had on the care of patients? Is that what you mean?
Exactly. And I find two things. So first, this substantially reduced how long people stayed at skilled nursing facilities, right? And so on average, it reduced the length of stay by around 13%. And then I look at, okay, well, did that affect patients? And so I look at some measures of health, mortality, and readmissions to the hospital. And I find that despite these large reductions in healthcare use, there actually was no change in healthcare outcomes. So this suggests that the care that was screened out was not necessarily super high value enough that when it was cut, that patients were harmed by it.
It sounds like you could look at those results a couple ways. One person may say, are you telling me you're just using some formula to kick me out of the skilled nursing facility earlier? And your research would say that that's kind of what they're doing. On the other hand, someone might say, well, one of our goals here is to reduce cost and have lower premiums. So therefore, we should be trying to find ways to not pay for care that doesn't really matter that much. And maybe your research also showed that that might be possible.
Exactly. And I think, you said it very well. Like that's the trade-off, right? Between more care is obviously more expensive. And so to the extent that there are opportunities to reduce care that is not necessarily improving patients' health, that does seem like something that health insurers should be doing to try to, reduce overall healthcare spending.
Now, you spent a lot of time on this project. A dissertation is not a weekend activity, as I understand. And so I wonder what you think insurers should be doing on a regular basis, because this isn't like the only clinical algorithm in effect. There are lots of them, right? So How do you think we can make sure that clinical algorithms are not harming patients?
Yeah, I think this is a huge question. And I think this is, over the last couple of years, it has obviously been getting more and more attention as AI has improved. And there's been a lot of concern that insurers are using algorithms pretty broadly. And it's not really clear how they're doing it and whether it's harming patients. And I do think that it is a very legitimate concern that policymakers have about the use of algorithms and this question that you raised of the unintended harm towards patients. And I think that it's just something that I think policymakers will continue to have to monitor and see how it develops. I think this is something that, over the next 10 years is going to be even more relevant and even more of a part of everyday care. And that's something that I think we're just only at the beginning of how regulators are going to look at that.
All right. Well, let's say your phone rings and it's a policymaker, and the policymaker wants to figure out what to do. What would you tell them to do besides just monitor the situation? Do you think that there are any policies that should be put in place to protect patients from, a company thinking, well, this will work, and then it turns out not to work?
Yeah, that's a great question. I'm not sure I have any good answers to that. I think, in some ways, my dissertation, I think the results suggested that, hey, this isn't something that's necessarily harming patients. And I think that I would have a different set of answers if that result had turned out differently.
Well, let me ask you this. Do you think that there should be certain factors that shouldn't be included in that algorithm? Is it fair to use people's income or race and ethnicity, for example, to predict how they'll do?
Yeah, and I think that would be a little bit concerning, right? If that's how you're deciding to allocate who gets to stay extra days at say, a skilled nursing facility, or, I think that would be somewhat problematic. And I think that's a key concern that I think some policymakers are definitely interested in and interested in watching, and something that I think is worth considering.
Let me ask you one other idea. If there's a clinical algorithm with a pretty big impact, do you think that companies should be required to study it, to hire someone like you or a company, or even internally, and then report the results? Hey, we put this clinical algorithm in effect, and here's how we know that it's not harming patients.
Yeah, I mean, I think that's not a bad idea. I think one thing that's been interesting about studying this is just how little public information there is about these algorithms that are making really consequential decisions for patients. And so I think there's definitely a need for more transparency by health insurers to sort of say, here's what we're doing, here's what we think we're doing. And if you're enrolling in our plan, here's how we're going to handle this type of decision. And I think that's something that is not the case right now.
Right. Well, I know these aren't easy questions, but you're going to be Dr. Jeff Marr soon, so you're going to get some more tough ones coming your way, I think.
Yeah.
Let me just ask you about your future. I understand you have a faculty position lined up at Brown University. Tell me about that.
Yeah, so I'm joining the Department of Health Services Policy and Practice in the School of Public Health at Brown University as an assistant professor this summer. Very excited about that, and really excited to continue working on topics that are of interest to policymakers, particularly in Medicare, and plan to continue studying insurance markets and all things Medicare. So I'm very excited to be able to do that.
Well, thank you so much for joining me. Good luck with all of your work.
Thanks so much for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.